really been looking forward to today's discussion with Dr. Daniel Kendall. And I really want to thank Jillian from Medtronic for bringing this to my attention. We bumped into each other the other day, and she said, "Have you done a discussion on pain?" And I said, we've never really done a discussion specifically on pain, but a lot of our discussions, families, caregivers, individuals are talking about the pain that they're going through. And I know personally, I guess they call it a compressed disc, where I had severe pain on my right arm for at least a 3 months. And it was one of those things that really opened my eyes to, when we're dealing with pain, how challenging it can be. And so let me welcome Jillian and Dr. Kendall to the stage. Let's get to know them a little bit better. And folks, just so you know, Dr. Kendall is off site, so we're going to be talking to him today to minimize any kind of technical difficulties that might have. But Dr. Kendall, can you hear us? And Jillian, I see you there.
Hey there, Steve. Thanks so much for having us today. I think we got Dr. Kendall on the line. Dr. Kendall, can you hear us okay?
I can. Thanks for having me, Jillian. Thanks for having me, Steve. Appreciate it.
Yeah,
Yes.
and just so you know, about 46% of our audience filled out the little poll we were running, which asks, "Are you joining today's discussion because you, a loved one, or a client is experiencing chronic pain?" Most of the people say yes. We've got a few that are here because of a loved one. We got somebody who's here because of their husband and themselves. We got somebody that says yes, the effects of Achilles tendonitis, numbness, tingling, burning pain in my feet, lower back, and knee arthritis. All of these make it very hard for me to exercise. And then we've got a handful of people that are here that aren't experiencing pain, but they're just here to learn. So I think we've got a great audience, and I want to remind the audience that you all can ask questions. So feel free to drop in to chat or use the Q&A button. And Dr. Kendall, I'll read those to you since I know you're off site and on a device that you might not be able to read that well. But with that, before we dive into that, let's get to know the two of you. Dr. Kendall, tell us a little bit about your background and what led to your specialization in pain.
Okay, thank you. So I'm a pain specialist. First of all, anesthesiologist. I went to medical school in Chicago and then did a surgical internship and a residency in anesthesia at Northwestern. And then from there, advanced my studies after finishing being an anesthesiologist, did a fellowship in interventional pain management at Johns Hopkins Hospital. And after graduating from there, I've joined Capital Spine and Pain Centers, which has multiple centers throughout Virginia and Maryland, and now a couple states. And I've been currently at the same job that I took from graduation. So 22 years in practice. I'm the director of our McLean office, so in Northern Virginia. And I've been treating patients with chronic pain from since my training through now. And it's it's been a fulfilling and challenging career, but just here to explain a couple therapies that we do in the practice and then answer questions regarding either these therapies or others that I do. So I appreciate you guys having me on. Thank you.
I love it. And then Jillian, tell us a little bit about your background.
Thanks, Steve. So I'm Jillian Benson, and I'm a therapy awareness consultant for Medtronic in the Northern Virginia area. So my role with the company really is to educate patients on opioid-sparing therapies that may exist to help them get relief from chronic pain. I also educate referring physicians and work directly with pain practices to try to create a care pathway for these patients that are living with pain and help minimize the number of stops on the train before they get relief and try to help those patients on that pathway. So like I said, I work with Dr. Kendall quite a bit. I cover the whole area. So if any of you on the webinar today leave with more questions or would like to know more information about the therapies, I'm always available. I'm willing and able to share my phone number and talk with you or loved ones about anything you learn about today.
Okay, great. And then Jillian, before we dive in, I love the phrase that you brought up. It was it opioid sparing pain relief. Did I get that correct?
Yep.
And you know, with opioids in the headlines, and they'll never leave our headlines, I don't think. I imagine that that this has really accelerated innovation and technology um, to find ways that we can be relieved of pain without opioids. Am I correct in this assumption to you and Dr. Kendall?
That's where I turn it over to Dr. Kendall for his expertise.
Yeah.
Okay, awesome. Okay.
Absolutely. These two treatments we're going to discuss today are opiate sparing techniques to take some ways to treat pain without high dose opiates, and much part of the practice of an interventional pain physician is about minimizing the opiate pills if you can, and use other techniques to help treat the pain. So it's apps, and there's technological advances all the time, and these are two of them, but we have other therapies as well that can help with that.
Okay.
Okay, so to start, I'm going to begin about what is chronic pain. Chronic pain is often defined as any pain lasting more than 12 weeks. So when we get an injury or what have you, if pain starts, as you discussed, you had a pinched nerve feeling for 3 months. So you were right on the border of someone who is been suffering from chronic pain. Obviously, can be very disabling. And but that's the basic definition. Do I have like something that's an acute pain or chronic pain? Although this is, this would be the scientific answer, 12 weeks. But obviously, pain can start right from the injury and further on. But once it persists despite the adequate time for healing, then it's called chronic pain. So we often in the clinic, we see chronic back and leg pain. It can result from several spinal conditions. It can be from degenerative disc disease. It could be from, they call it failed back surgery syndrome. So that's patients who have had surgeries, who have continued to have pain in their back and legs, lumbar disc herniations, scar tissue in their spine. So multiple things can cause back and leg pain, multiple pathologies in the back that can be treated without opiates. Next slide, please. A certain condition we treat called complex regional pain syndrome is something we see in the clinic. It is a nerve pain condition that often affects arms, legs, hands, or feet. Typically, it is patients who have hypersensitivity to touch. Also could have temperature changes, like your hands feel cold when others do not. They also feel like you're losing. You can get atrophy, so I mean like muscle wasting in the hands. So, but basically, pain that can be out of proportion to the injury is a disease called complex regional pain syndrome, possibly. It is also known as reflex sympathetic dystrophy. It usually develops after a nerve injury, or it could even develop after a minor injury. So if there's pain, like neuropathy pain that's unexplainable, you could be suffering from this, and you may have ways to treat it. Next slide, please. So painful neuropathy, so burning pain, pain that's typically due to nerve damage or it also can be result of diabetes. So pain and numbness sometimes come together. Sometimes it could be nutritional imbalances. You can get an alcoholic neuropathy. You can be exposed to toxins and have this pain. Chemotherapy agents can cause pain, infections, autoimmune diseases, trauma to nerves or illnesses, and cancer can even cause this challenging pain syndrome that we have options to treat now. So what are the options? So first, when you see your doctor, they start thinking about medications to treat the pain. They sometimes prescribe physical therapy. If there's a significant psychological component, they may get a psychologist involved. They start thinking about maybe alternative therapies, such as maybe acupuncture. Is there a corrective surgery to help the neuropathic pain? Often there is not. You can sometimes do injections to try to relieve inflammation within the nerves. And then there are these medical devices that I'll be talking about, specifically spinal cord stimulation and intrathecal pump placement. And there's also sometimes you can ablate nerves, called neuroablation, like knocking the nerves out with a procedure. So next topic. And if you've tried some of these things and therapies and still have chronic pain, then you'd be a good candidate for seeing a pain physician to see what other potential therapies there are. Now, there are chronic pain therapies kind of that Medtronic has that can give you a path to help improve your pain, not only pain, but also improve function. And unlike surgery, the nice thing about these therapies is that you can try it out before actually proceeding with it. So they are implants that can be done for chronic pain. One is called spinal cord stimulation. Another one is called targeted drug delivery. They have long-term proven track records for treating chronic intractable pain. And one of the benefits of these is that you can undergo a trial to see if you're a good candidate for it. Next slide, please. First, we're going to talk about spinal cord stimulation. Now, how does spinal cord stimulation work? It disrupts pain signals traveling from the spinal cord and brain. So if you get pain in your legs, it intercepts pain signals from coming into the spinal cord. And what is involved there is that with the trial, essentially through a needle, these leads are placed. They look like electrodes or like little linguine noodles, if you will, like pasta noodles that are placed into the back and help block pain signals from coming in to the spinal canal. The nice thing about it is that there's no medication involved. It's like an electrical stimulation. For the trial, the battery is placed outside the skin where you would go home and try it out for a week. The permanent version is attached to a battery that's about the size of a pacemaker. So I know a lot of patients have pacemakers for helping with their heart out with heartbeats. This is essentially like a pacemaker for pain control. And it sends impulses near your spine with these thin insulated medical wires called leads to help disrupt the pain signals from traveling to the brain. So basically, essentially outsmarting the brain, trying to help block pain signals. Now, some patients would ask, does this mask all your pain? Are you numb and can't feel anything? No, this only works on the fibers that fire pain. It's called the dorsal column fibers in the spine, and they focus on the pain sensing fibers. So you would still feel your body, obviously. Now, looking at the next slide. Now, to see if something like this is right for you, it's really appropriate to get a consultation with your pain specialist. But just to go over the procedure here is that the nice thing about the spinal cord stimulation is that you can test drive the therapy first. So what that means is that before getting like a device implanted in your body, there's a temporary one that can be placed essentially in the office or in an ambulatory surgery center, depending upon what the doctor facility he uses to put the device in. But essentially, during this trial, you assess how well the neurostimulator relieves your pain, and it's typically used for approximately a week. And then during this time afterwards, you assess how much pain relief you had and how much more functionality have you had. Were you, before having the stimulator, were you having trouble standing for periods of time? Like, were you having difficulty standing for approximately 2 minutes before getting your pain, and now the stimulators allowed you to stand for 2 hours, would be an example? Or were you having trouble walking to the mailbox to collect the mail, and now you can walk beyond the mailbox and perhaps another block with the therapy? So ways to assess your functionality and pain relief are important with determining whether or not the stimulator is right for you. And we can go on to the next slide. So how does the trial work? So first, the leads are placed in your back, like I was talking about, near your spine, through a needle. So they first numb up the area, and through a needle place these wires in your back, like in the epidural space, and then stimulation is applied during the procedure, and the doctor will ask if you're receiving the stimulation in the appropriate area. And then they're connected to an external wireless neurostimulator or battery that's secured to your back that you get to go home with. And in the recovery room, they run over some programs and you can have control of these programs, whether you could push certain specific programs for the stimulation of these leads to block pain signals, or if you want, you can also just run a program in the background and not use the patient choice for options. So there's a couple ways to attack this. The stimulation these days can be a high frequency mode where you do not even feel the stimulation. It's running at such a high frequency that the patients do not perceive the stimulation but perceive pain relief. So that has been a common trend in the past 5 to 8 years. So patients really love that, but some people do love the feeling of the stimulation, so they run it on a low frequency mode, and that can help block pain signals. So if we could go on to the next slide. So after the trial, so you basically go back to see your doctor, and then the leads that come out are pretty simple. They just take the tape off and come out. And before the permanent version is implanted, they obviously schedule you for an outpatient surgery. So it'd be similar to getting like the pacemaker placed. And the device is placed in the similar area in your spine that the trial was implanted. So when we do the trial implant, we put it in under X-ray guidance, and where the electrodes are in your spine, that's where the permanent version would be placed, and it's used as a map. And the procedure typically takes about 30 minutes to an hour, both the trial and the permanent. So a very short procedure that you would go home the same day. And then after the procedure, you would follow up with your pain management doctor and then the representative from the stimulator company, and they'd make sure that you were very comfortable with the device, and if you needed any adjustments, it could be done. Next slide, please. So many people, when they find these, so they've tried physical therapy, like I talked about, different medications for nerve pain, like such as gabapentin and Lyrica and medicines like that, and have really struggled with chronic pain. And this can be a device that is not using medicine and can significantly change your impact view on life, and just change your mood and feel better about the positive aspect of aging, right? You've gained the maturity and the knowledge of life, right, as you've lived. So you want to live without pain, and this is a device that can really make a significant impact in your quality of life without having potential any side effects with medications prescribed. And there's no, once the permanent one is in there are no limitations on activity. Next slide, please.
Yes. Dr. Kendall, I don't mean to interrupt, but I think Ken has a really good question, and I'm hoping you can sort of answer it with the elevator, speech, and then we could dive deeper into it. But he's asking, is there a standard approach to intervention? Example, like oral medication, PT, local injections, and that we will go through before we think about this technology.
Okay, that's a great question. Great question. So yes, so there's a typical standard when you come in to a pain clinic. They see first to see if you have failed the most conservative options first. So if you're able to control your pain on like a nerve pain medicine that is safe for your body and you're not getting side effects, obviously that would be the most ideal to control this. Some people and have undergone perhaps physical therapy to see if the pain is controlled. But however, if the patients have had side effects or have had difficulty finding medications to help them, then is the pain blockable? Like that means is there an injection that you could give numbing medicine and the corticosteroid, which is essentially an anti-inflammatory to reduce inflammation in a specific nerve or nerves that will help get long-term pain relief. And perhaps sometimes that's helpful as well in diagnosing the condition. So you could do a nerve blocks to help diagnose what kind of problem you have. Like, is it coming from the spine, for instance, or rule it out? Is it something more of a diabetic neuropathy type issue? Nerve blocks can be effective for that. But when those are not lasting and medications are a problem and you have failed physical therapy, then you start thinking about more advanced therapies. And not all pain clinics have these options of spinal cord stimulation. You need advanced training for that. So if you go to a clinic where they do not offer you that, you may want to consider, you know, thinking about getting a second opinion, because there are quite a few doctors that do this, but there are pain clinics that don't. So this is called essentially like advanced therapies for treating
Okay.
pain.
Okay, no, I think that's great. And like you said, we can dive deeper into any specific questions, but this is fascinating.
Great. So the benefits of spinal cord stimulation: long-term effect, pain relief with improved quality of life. It's more effective, especially in the spinal canal. Once you've had one spine surgery and it hasn't worked, and then the surgeons try again for a second and third, it is shown head to head that after one spine surgery that the spinal cord stimulation has been better for pain long term than having repetitive operations. It also improves the ability to improve your activities of daily living, such as walking, spending time with your family. It's effective for typically done for pain relief of the extremities, back and or leg pain. That's what they call it, trunk and leg. So basically back and leg is most common, but it's also been used in the arms as well. Your therapy can be personalized. So like I said, you could have like a program in the background that goes all the time, or you could have specific channels that you use, specific waveforms that you use to help block pain signals. And you may use one at night to control your pain one way, and then one during the day, for instance, another way. And controllable means you can turn it on and turn it off. If you do not want the stimulation on for whatever reason for amount of time, you have control of that through a handheld device. And multiple studies have shown its efficacy to reduce oral consumption. So some people are on chronic opiates, and once they get the spinal cord stimulation, are able to either come off it or definitely reduce them. Next slide, please. So choosing the right system, there are a couple batteries. I'll just go over this briefly. But once you decide to get a permanent battery, these last about approximately 9 years. They are MRI compatible, which is nice. They're small implantable, thin devices. You can see the relationship it is to a quarter, so very small. So similar to pacemaker company Medtronic makes pacemakers. So they're experts in making these batteries, but they're small and implantable and thin. So, and next slide, please. And then you can have a choice whether or not you want one that's rechargeable or non-rechargeable. So if you're a patient that likes control and you want to recharge your battery will last longer if it's a rechargeable battery, but you can also have a non-rechargeable battery that can last for 5 to 10 years. So if you don't want to mess with charging it, then you can have a non-rechargeable battery. If you want a rechargeable one, you may get some longevity out of it. The length of the battery time is based upon how often you're utilizing and how much power you are utilizing in your stimulator. So some batteries can last 10 years, some last 3 to 4. The recharging is typically once a week with patients, but it can vary depending upon how much power you're using from the battery. Next slide, please. And like I said, you can have personalized pain relief with the proven therapies. Next slide. The risks of spinal cord stimulation are similar to injection. So, bleeding, nerve injury, infection is what we always say when you give an injection, but extremely low risk. I've done spinal cord stimulation for over 20 years now and have not had any serious complications. Sometimes when you put these leads in, these linguine noodles, if you will, that's what it looks like, they can slip and that becomes a complication. I had that one time where you had to go back in and put them back in place. But generally speaking, we worry about reducing a risk for infection. We do give antibiotics during the trial phase and also during the permanent to reduce risk of infection, although it's extremely low risk. And bleeding, I've not had, and nerve injury, I've not had, similar to having like an epidural catheter, for instance, in labor. So for the women that have those, this is essentially putting the leads in a similar space, but rather than delivering medication, it delivers the electrical current I was talking about. Next slide, please. Okay, then the other therapy I was talking about is pretty interesting, is targeted drug delivery. And what that involves is, okay, so when we take medications, obviously you can take them by mouth, so it's called oral systemic delivery. So if you're taking pain pills, you can be delivered there. It can be delivered through an IV, for instance. It can be delivered through the muscle, so intramuscular, or it can be delivered into the spine, and that's called intrathecal drug delivery. And the how it is delivered through the spine is there's a pump implanted in the skin, and then you can give tiny doses of medicine from the pump that goes into the spine. And the nice thing about it is that you can deliver better pain control at the fibers in the spine. For instance, if you're giving pain medicine into the reservoir that's containing the pain medication, for instance, let's call it morphine, for instance, it goes right to the spinal canal where the receptors for pain exist, and that in doing so, it bypasses what we call the oral bypass system, where you do not have to digest the medication and go through metabolism, so you can use much less medication through the reservoir than via the mouth. A lot of times 1/100th of the dose. So for instance, if you're on 100 milligrams of morphine, you could get away with giving 1 milligram of morphine through this pump. Next slide, please. So you can get the right amount of medicine to the precise location. So why would people get a pump? So it's for people who are taking pain medicine, who are having side effects potentially from the medicine. It's either making them drowsy, constipated, confused, they're unable to tolerate it. Or patients that maybe do not want opiates but do not respond to the other medicines. There are medicines that you can give in the pump, like ziconotide, that are helpful for treating pain. There's numbing medicine you can give through the pump. There's muscle relaxant called baclofen for spasticity that can be given through the pump. Perhaps taking pills is a cumbersome thing for your patients, so perhaps you're having to take oxycodone or Percocet every 4 hours, and that is cumbersome for the patient who's in pain, and also for the caregiver. So if you have to like be around the clock watching, when the next pain dose can be delivered, rather than doing that, it could all be delivered through the pump, and it's much easier to control. You can have a continuous infusion in the background, and where the patient can even dose themselves with lockout periods. So something that can be more convenient for the caretaker. And also with the less dose of delivery through the pump, it gives less chance for side effects, so hopefully more coherent patient, especially important for patients who are elderly with dementia and other factors that are leading to cognitive decline. This is a really good therapy for them, where they still require some pain medication to get their pain under control. And how is it done? It is also done through a trial. So next slide, please. So another device that you can test drive before actually having the permanent version. It can be done through an injection of pain medicine in the spinal canal. It's just done as an outpatient, like a simple injection, or a catheter can be placed for a continuous infusion. Next slide, please. So the injection is done, or the catheter is done, and then you come back and see your doctor, and you describe if you got pain relief or not, or if you had side effects, perhaps with oral pain medicine. It gave you various side effects. Did the intrathecal one give you the same side effects as the oral medicine? You would report that to your physician, how much pain relief you had, and then determine if you would like to proceed with the permanent version of it. The permanent version, like the spinal cord stimulator, is done typically in an ambulatory surgery center. It's an outpatient surgery, typically 30 minutes to 60 minutes done. And then you would have follow-up visits with your pain management physician to essentially get the reservoir filled. And then programs, there's different rates that the medicine can be delivered. And then you would need refills, typically on a 3-month interval, that go in through the reservoir. Next slide, please. So typically when patients get these trials, it's immediate pain relief I'd say within an hour, you can notice a significant difference. And like the spinal cord stimulation, can make a significant impact on your life. Next slide, please. So like the stimulator, you can have control of these pumps, so you can have a continuous infusion, and then you can also control it by dosing yourself, to not overdose yourself. There are what are called lockout periods, where the patient can only give themselves, like for instance, like one dose in a 2-hour period, and then it would give the opportunity to give a second dose. So it's therapy depending upon, that's customized to the patient's pain issue. It can be given around the clock, or as a PRN, or both. Next slide, please. So we talked about the benefits of it. It can basically, the ability to improve function and participate in your daily activities, provide effective pain relief, improve your quality of life. 90% of the patients with a pump would recommend it to a family therapy or friend. Okay. It'll likely eliminate the use for oral pain medications. A lot of patients come off their pain meds completely. There's obviously fewer side effects because you're giving lower doses of pain medications, sometimes 1/100th of the dose. And in one study, they showed that over half the patients completely eliminated their pain meds, no matter what their doses were, after 12 months of the implant. Next slide. The risks with this are similar to spinal injections. You could have, like I talked before, but also a spinal headache or any dry. You can still, even though with such a low dose of meds, you can still have side effects. So those are monitored. Surgical complications can occur, but rare. Next slide, please. And I guess to conclude, these are 2 treatments that have opiate sparing techniques that we talked about that could give great pain relief with improved quality of life. They're There are other treatments we do in our clinics as well, but today we highlighted these two specific treatments. So if you're not a great candidate for this, or you have, for instance, a problem like a osteoporotic compression fracture, or there are treatments for that as an outpatient. There are treatments for degenerative disc disease, other fascinating treatments that do not involve implants as well. So if you are unsure of what treatment you need, it's good to come in and get evaluated and by a pain physician, and they could kind of go over the various new technology and advances for treating chronic pain.
Man, this was great, Dr. Kendall. I had no idea that this technology existed. And we've got a few questions. Can you hang on for a little bit and we'll get through those?
Okay, let's try it. Let's give it a shot.
Okay, all right, here we go. David asks, does the stimulator reduce abdominal pain?
So there has been we've used stimulators for abdominal pain. The benefit of the trial is to see to see if it works. So that it really depends if it's neuropathic or if it's organ related or somatic or muscular. So the stimulator is better at treating neuropathic pain. So sometimes with abdominal pain, the intrathecal pump is a better option. But the nice thing about the spinal cord stimulator trial is that you would try it out for a week and assess it for yourself. So there's no specific, like you'd have to essentially, if you failed other therapies, that's something to consider to mention to your doctor. But it's generally for neuropathic pain, so nerve-related pain. Yeah.
Okay. And then Paula asks, can a patient have one implanted if they already have a pacemaker, or is there any interference with that?
It's a great question. I've got patients with both pacemakers and stimulators, and yeah, there's no interference whatsoever. In fact, a lot of patients feel comfortable who have had like pacemakers with like companies, and then they have this the pain stimulator with the same company. But it typically there are different reps, so you don't need to necessarily use the same company. But yes, there are many patients have pacemakers and spinal cord stimulators, no contraindication.
Okay. And then Mary asks, are the pain treatments ever used in oncology treatment? A friend's father with dementia has increasingly painful bladder cancer and is unable to undergo chemo because of his dementia. Um,
This is a absolutely fantastic question. So the great a great treatment for that would be the intrathecal pump placement, because you can deliver a much better pain control with the pump. You could use higher doses with less side effects, and that has shown to help people undergo their treatments. There are also nerve blocks used for cancer pain, but the intrathecal pump, we often place it for pancreatic cancer, bladder cancer, and it's essential to get your pain under control so you can get the appropriate therapy. So that was a fantastic question. Also, patients with cancer also can get metastasis to their spine, and we have different treatments for that, for treating cancer pain related to the spine, that you can help knock out spinal tumors within the vertebral bodies that we do, and help with solidified fractures in there. So there are various treatments for cancer pain that a pain specialist can do, but specifically what we talked about today, this intrathecal pump, is a fantastic idea for the specific case you just mentioned.
Okay, great. And then Rosalind asks, is there any pain treatment for vestibular migraines? Have you encountered any of your patients with that?
Okay, I'm sorry. Can you repeat the question? It just
It's
came
called
out.
vestibular migraines.
Oh, vestibular migraines. Okay, challenging, challenging thing. So for vestibular migraines, migraines are difficult in general for for intrathecal pump placement for, for our injections that we do for migraines. We think about Botox treatments, but for specifically vestibular migraines, it's extremely challenging. And I typically would send to a ear, nose, and throat specialist first to evaluate to see if there's any specific treatments they have before we would undergo medications. But that is a challenging disease that, as pain specialists, we constantly look for new treatment options. But sometimes vestibular migraines can be coming from perhaps arthritis in the neck, can initiate the onset of them. So sometimes we treat arthritis in the neck and see if that helps with their migraines. But that is a challenging disease. Yep.
And then, I know that you've got to run. So, a couple of, let's see. Well, Mary just asked a question. Any option beside corticosteroid,
Right.
corticosteroids for knee arthritis?
So absolutely. There's something called a genicular nerve block and radio frequency procedure that we do often for knee arthritis, as well as if you are not a great candidate for a knee replacement and you've had radio frequency ablation of the genicular nerves that are done in the clinic, you could also have a peripheral nerve stimulator. So today we talked about spinal cord stimulation. There's also peripheral nerve stimulation that can be done for a nerve, knee arthritis. And it's the same thing. You would undergo a trial for approximately a week. And then if you found fantastic relief, you could get a permanent version of a little peripheral nerve stimulator for knees. So it's really good for people who are not good candidates for knee replacement. But also I would try radio frequency ablation before the knee replacement as well.
Okay. And then Ken has a really good question. How long does relief last before the stimulation is no longer effective?
I mean, being in practice 20 some years, I have seen sometimes the stimulators not be effective over everybody's a little bit different, but where it could be less effective over time, but most people find them effective and prolonged relief. Most studies show that there's relief beyond 5 years, but for the patients, let's say, that are receiving less relief, a couple of things need to be done. The pain generator needs to be reevaluated to see if something has changed. And also with the new technologies, you can use different modes or different waveforms to control the pain. So sometimes you would just change it from a low frequency mode to a high frequency mode and give your body a break from the one frequency that was used. And then that's often enough to get the pain under control.
Okay. And then somebody asks, chronic arthritis pain, is there any care advances for those folks?
Depends. So in pain management, we try to isolate the arthritis, whether it's a knee, hip, um, uh, shoulder, those areas. So similar, you could do a peripheral nerve stimulator for that. You can do this with this procedure I call radio frequency ablation, where you deaden the nerves that fire pain related to the joints. So there's also a whole nother topic that we could discuss on another day called platelet-rich plasma and stem cell therapy for chronic arthritis. So, but I'd say that's a good summary.
Yeah. And actually, I think I'll work with you and Jillian, and I think we should have a discussion on arthritis. Another question came in on arthritis being more challenging during cold weather, but I think just understanding what arthritis is and the various treatments for that would be very beneficial.
Fantastic.
Okay, here, I'm going to make these two. I know you've got to run, so let's do these two last questions and then we'll wrap this up. Rosalind asks, what if the Medtronic gastric pacemaker is already implanted? I think you addressed that you haven't had any interference with those.
Right. No interference. You can go ahead and try the stimulator trial. Absolutely.
Okay. And then back, this is, so many of the families that are in our community are dealing with loved ones with dementia. And Eileen says, since dementia can also cause pain, how does it affect your treatment recommendations and outcomes? And it must be really challenging, Dr. Kendall, when your patient can't really communicate with you appropriately to identify pain and things of that nature.
Yes, often those are the most challenging patients. You have to rely on caregivers and whether or not their quality of life is improved. Like, are they, do they, are they eating better? Are they in, are there some interaction that is not verbal? Are they, what their quality of life is. So that's where the family members and caregivers are important in talking to when you're analyzing pain control. Sometimes dementia, sometimes it can be side effects from medications are on or contributing to it. So that's some of the benefits that you can do when you see a pain specialist, to try to see if they have ways to not use the medicines to try to help alleviate pain, to see if it improves.
Okay, great. And then
Thank
I think that's I
Ha!
okay. One last one. Okay, kidney and liver, other organs affected by pain medicines, can they improve with these new care plans?
Um, so that's a tough damage that's already done. I mean, I would say that I would have to leave that for the endocrinologists that are managing that to determine, like, what's reversible, what's not. Often liver disease is reversible. Kidney disease, is difficult, but the benefit of these devices is that you would require less medications. So you would hopefully not be relying on medicines that are contributing to those diseases, such as anti-inflammatories contributing to kidney disease, for instance, or acetaminophen maybe to liver disease. So there are good options to pursue that do not affect the kidney or liver. So that these are great options for someone with those diseases do not want to be exposed to medications that contribute to
Okay,
them.
great. Man, Dr. Kendall, this has been amazing. Jillian, thank you so much for bringing us Dr. Kendall. Um, I think it's just really important. There's so many advances in medicine that if you talk to a practitioner, like as Dr. Kendall had said, if you're not an advanced pain specialist, you might be talking to a pain practitioner that doesn't know that these advancements are available, or advanced things are constantly changing. And you talked to a pain specialist 20 years ago and you're still undergoing that treatment.
Thanks for having me, guys. I really appreciate the
You bet.
opportunity to talk.
All right. Thanks,
All right.
Dr. Kendall. We'll
Well,
All
talk to
right.
you soon. And
Okay.
thank you,
Take care. Bye.
Jillian, as well.
thanks, Steve. I really appreciate it. And what you said is absolutely right. So the reason that people like I exist in the world is to help people know, to help educate people about these therapies that exist and how to get access to them. So I think that's why, as a therapy awareness consultant, my goal is to help patients gain access to care. So like I said, if you have any questions, Steve knows how to get a hold of me. I can help you navigate this pathway. If you have any questions after today.
And I've got your contact. I'm going to put that on the link with the recording. That should be up later this afternoon. And folks, I hope you got something out of this discussion. I think that that poll that we did at the beginning, to know that some of you in the audience are in pain right now, or that your loved ones are in pain like now, my heartfelt sort of sympathy for you, because I've just temporarily had to deal with that, and I know how challenging it can be. But it really is great to know that there are some treatments like this. There's practitioners like Dr. Kendall, and advancements in technology with Medtronics, to hopefully will someday live in a world where nobody has to deal with chronic pain. So thanks a lot, y'all. Thank you, Jillian, and we'll see y'all next week, or at the next discussion that you choose to join.
Thanks, Steve. Thanks, everyone.